I can get us
I'll
started off with a question, if that's
go ahead.
okay.
Yeah.
Um, I was curious. We had a discussion on prison health a few weeks back, and I was curious what your experience was, kind of managing the hospitals versus managing the jail hospitals. If that was a different or a challenging experience in any way.
Yeah, so I think it's unfortunate that in most prisons in the United States, they have outsourced the care of patients to for-profit entities. Um, we've actually been awarded several times, most recently during COVID, for the quality of care that we provide to our detainees, and we refer to them as detainees, as I said, because they've not been convicted of anything. As a matter of fact, our doctors are, instructed not to query the patients why they've been detained, but really just to treat them as any other patient and um, provide for their needs. Many of them have not had access to medical care, so everyone who's admitted to the jail gets a screening exam, and we make an assessment. It's important to do that because more than a third of the detainees are in jail for behavioral health or mental health problems. Um, why does someone get arrested 142 times for trespassing? That's someone who's having a problem. And I think that we don't do enough to make an assessment as to why people have wound up in their encounter with law enforcement. And mental illness has a lot to do with it. And so we were for many years under court order to provide comprehensive behavioral health for the detainees. And because of that, the restrictions, we actually have more mental health providers per capita in the jail than we do for the entire rest of the county. Everyone is screened, and we try to make an assessment. It helps us, I mean, because we also do the juvenile detention center as well as the adult jail. Um, and we see a lot of crossover of kids who come, we first encounter in juvenile detention, who we later encounter in the jail. And it has to do with our failing to meet their needs or addressing their issues. And whether it's that they come from chaotic backgrounds or whether they have underlying mental illness such as schizophrenia or bipolar disorder that's just not addressed and not treated. So we do a lot with, we have mental health technicians. There are a lot of encounters aside from using psychiatrists and psychologists. Um, we try to do a lot of on the ground um, group meetings with folks and really try to help people develop some perspective on how they're problem solving and how they deal with stress and how they deal with their problems. I think that's one thing. But the other thing is that um, people have untreated hypertension, undiagnosed diabetes, they have coronary artery disease, they have cancer, all kinds of things that have, most of the time, people who are dealing with our um, correctional health have not had regular access to physicians. And our biggest challenge is because they are in jail, they may go to court and be released, is try to establish some continuity so that when they are released, that we can maintain that contact and provide them access to health care. But in general, providing health care to people in a detained population is challenging because you have to have a lot of cooperation from law enforcement. In this case, we're working with the county sheriff. And because they have staffing issues, sometimes they require that there be two officers to escort any detainee to any appointment for a hospitalization. And as a result, we struggle sometimes. For example, we provide dental care for the detainees, and many of them have not had ongoing dental care. We had a young man in our juvenile detention center who was admitted time and time again um, for really aggressive and violent behavior, and it was just miraculous how we were able to address some problems he had with his teeth. He was self-conscious about his mouth, and that when his teeth were fixed, he didn't come back anymore. And it was like a real win. The dentist and the orthodontist, everybody was so proud of this what they consider to be a win that we saved this young man for our society. So it's hard to provide care in that context. Um, Law enforcement is not geared toward that, and it's very challenging. But I really stress with the docs how important it is to understand law enforcement's hierarchy and their structure, and how to try to have a cooperative um, relationship so that they don't feel that you're always judging them, and you can build a collaborative relationship as opposed to an opposition. Because a lot of docs will, have their opinions about police or police officers, and that can interfere with building a collaborative relationship, which will allow us. Our ultimate goal is to provide the best care possible for the detainees. I don't know if that helps you or not, but it's an attitudinal thing that we struggle with.
Yes, thank you so much. If anybody else has questions, we'll open up the floor. Yeah,
Yeah.
Lauren?
Well, hi, Dr. Fagan. Thank you so much for your talk. I'm actually really interested in working in like public hospital systems in the future. So from your perspective as someone who worked both as a physician and now in administration, how do you feel like I guess your biggest priorities slash issues have sort of changed from being a doctor to being an administrator?
Well, I never stopped seeing patients, right? Even as an administrator. And unlike in other systems, I think this is more common in private systems, but it happens in public as well. I have an expectation that all of my leadership have um, time dedicated. My department chairs are expected to have at least 20% of their time with direct patient care, because you can't really have an appreciation for the system, how it works and how it doesn't work, unless you're working in it. But my reason for going into administration was um, really once I had an understanding of process. I will say to you that there are no bad doctors. There are failures of systems, and that healthcare has to be, we've gotten much more into algorithms or protocols in terms of delivery of care that are based on data, based on published studies, where we learn that, this regimen of antibiotics is probably the best. Now, there are exceptions to everything, but also understanding that you have to have processes for the safety of patients, that people intend to do the right things, but because they are busy, because they're under pressure, they make mistakes. So, what are the processes we can put in place to try to prevent mistakes from reaching the patient? I had a dear friend when I was in private practice. And I was in private practice for about a dozen years after I got laid off from the Health Service Corps, and then went into private practice, and then went to work for the county. But I had a friend who was a very busy, very famous orthopedic surgeon, and he was in constant demand. And, this was back in the 80s, and he operated on the wrong leg of a patient. Um, and so, since that time, we have in process that, you mark the leg, you mark it with a marker so everybody knows if, or the arm, or wherever you're supposed to do the procedure, and you initial it. Now that seems ludicrous, but, running from room to room and seeing a lot of patients, it's possible to make a mistake. In the hospital, insulin is a dangerous drug, and a nurse is not allowed to give insulin without another nurse looking. So she draws up the insulin for a patient, and then has another nurse look and says, okay, this is patient Mr. Smith. He's supposed to receive 16 units. This syringe, I've drawn up 16 units. And the other nurse looks and says, yes, that is Mr. Smith. That's what it says. And yes, that's what you have in the syringe. So there's an expectation. You put in place processes that protect people, protect the patient, and also protect the caregiver, because it's a devastating thing to make a mistake that is harmful. So, why I think the public system is good. I think that it offers a lot of advantages to us. We take care of, lots and lots of patients. Um, over 1 million visits to our emergency department every year. But what I find the focus as a provider is advocating for your patient. We don't have a real health system in this country. It's incredibly complicated to navigate. And when you're working in the public sector, you have to be the advocate. You have to help your patient find the path to what their particular needs happen to be, and whether that's, a diabetic who you're trying to get the appropriate medication for, or whether it's a patient who has mental health problem in addition to their blood pressure. At Cook County, we even have a housing division because we recognize that patients who get admitted to the hospital again and again, sometimes it's because they have unstable housing and they can't maintain their regimen. So it's recognizing that there is a holistic approach, and it's a challenge, but you feel good when you're successful, and I think that that's why it's so gratifying to do. I don't know if I answered your question.
Oh yeah, that helped a lot. Thank you.
But I really got into administration because I studied quality and quality processes. And once I had an understanding that when mistakes happen, it's usually because a bunch of things have gone wrong, not just one person made a mistake, but there were a number of failures. And that the goal is to uh, address, try to anticipate those failures and put in place things that are protective, or processes. And that happens on the outpatient basis as well as on the inpatient. Yes, Anana?
Yeah. Thank you so much for sharing all of that. I wanted to know, as on the administrative side, what the general attitudes of other administrators are towards efforts like PNHP or things towards Medicare for all and things like that.
Yeah. So it's very interesting because when I was the medical director for a private hospital before I came to work for Cook County. And I remember one of my friends saying, "Oh, when I was a member of PNHP, oh, you're one of those fringe groups." Um, and that's not the attitude I get. I don't get that attitude at all anymore. But most often, people say that, well, we're probably going to wind up with single payer sooner or later, because everything else has failed. Um, there are so many studies that show that we are already spending enough on healthcare in the United States, and that we could afford to provide care for everyone if we did away with the bureaucracy of the insurance industry, which is unfortunately more focused on profits than on the delivery of care. And you see that in some of the practices that they've developed. But when I first went into working at Cook County, there were some folks who were kind of like skeptical of me, but it's changed. Fortunately for me, well, that was about halfway through my career. The current president of the county board was previously my alderman, and she and I used to battle all the time because I was the president of the local cooperative grocery store, and we were always, you know, making requests or demands of her. But our relationship changed when I came to work for the county, and she knew that I was a single payer advocate, so she kind of accepted that. I think it would have been hard for me to ascend to the role I was in as the chief over the entire system if she wasn't accepting of that. So I was always very careful to say when I was speaking on behalf of PNHP as opposed to when I was speaking on behalf of the county. But they pretty much knew that I was going to be on the news or at protests talking about single payer. But more and more people in healthcare recognize that just the challenges of providing care for everyone, and the cost of care, and it's a clash of the titans with the insurance industry. The Cignas and Uniteds of the world dictating what care patients can have. Yeah, exactly.
This is building on that question, but what did you find was the most effective way to communicate like what PNHP did or why you thought it was important to other physicians? Because it seems like over your career there was a large attitude shift. Do you feel
Mhm.
like you maybe contributed to that with discussions you were having, or
I
what do you
wish
think?
I
Okay.
did. I think that the increasing frustrations with healthcare, for example, the classic example I'll give is prior authorization. That if you look at Medicare Advantage plans, which is a private product, and the majority of people in Medicare today are in Medicare Advantage plans. And I think it was 2023, they they had almost 50 million requirements for prior authorization for medications, durable medical goods, tests, which was an average of almost two prior authorizations for every one enrollee. Whereas in traditional Medicare, over the same time period, they had only 400,000 requirements for prior authorization. Prior authorization is when the doctor orders a test or orders a medication or orders a patient to receive a treatment, and the insurance company says, we're not going to approve that. We need to put it through a process and look and see whether it's indicated. And what they found with the prior authorizations for the Medicare Advantage plans is that the majority of the time they would deny whatever was being requested. And the problem with that is that patients get discouraged, doctors get frustrated, and they give up. They do something else. They don't seek the treatment or a test or um, equipment that that they had ordered. But the problem with that is that when people appealed and less than 10% of the denials were appealed, over 80% of them were overturned. In other words, the prior authorization was just a roadblock. And what they counted on is the majority, 90% don't appeal. But because when they're appealed, they do wind up having to pay for the service. And so that's that sort of thing frustrates doctors. It adds time to their day because it's time that they're not spending with the patient. It's time when they're not charting, but they have to be on the phone um, trying to explain why it is they think this test or this treatment or this medication is important for this particular patient. One patient that I took care of for more than 20 years had a very complicated seizure disorder. And the average period of time that someone stays in a particular insurance plan, because if it's an employer plan, people get insurance from their employer, is less than 2 years. It's about 18 months. And every time, and she worked for Commonwealth Edison, which was the electric company. And every time they changed plans, they would want her to go back to being on Dilantin. Well, she was on third stage seizure drugs, and it made no sense to take her back. And I'd have to argue with the insurance company, and eventually they would always approve it. But those sort of things are what contribute to physician burnout. They're the sort of things that frustrate patients, frustrate physicians, and it's why people have moved toward wanting a single payer because they recognize that these things are not about care; they're about profits. And docs are just, there are a lot easier ways to earn a buck than being a physician. And you can make a lot more money doing other things. So most people who go into medicine are mission driven. And to have unnecessary barriers in their way to do what they feel is best for their patients is frustrating. And that's what's really moved people towards single payer. Um, I think that when I present physicians with the data, when I do presentations, the response is overwhelming. But you know, physicians for a national health program, we're maybe 20,000 physicians. That's such a small portion of the number of docs. I think that we make more of an impact when we explain it to patients because when I speak in community groups or in churches, because folks are just like livid to realize how much money is wasted um, with these unnecessary things. We just have to get the patients to demand of their legislators that they pass it. And that's the biggest challenge. There are currently 3 health industry lobbyists for every single member of Congress. And so trying to get people to agree to change is always difficult and challenging. Yeah, Natalia.
I guess I was wondering if there have been times when being a hospital administrator has been at odds with your personal values? Because obviously you have very strong values aligned with PNHP and single payer and taking care of patients. And I just wonder if there are times when that conflicts and how you resolve that.
Well, I think that not really, and I think that's only because I work in a public system. I think if I was in a private system where there would be more focus on, um, financial outcomes. We do say sometimes, and this is harder because more and more patients, poor people are in Medicaid managed care programs that might not allow them to be seen at Cook County because their particular insurance plan doesn't have a contract with us. And, I never like to turn any patient away. And so that's my thing is first take care of the patient, which does probably put me at odds with our CFO who says, okay, if you knew they were out of plan, why didn't you get them to where they were supposed to be? And, it's sort of like a passive aggressive. Well, first we had to take care of the problem in front of us, and then we're willing to transfer them to where they're supposed to be. But for so many years, over 185 years, 190 years, county has taken care of everyone who came to our door, regardless of where they came from. Which, some of the county board people don't like that because that means that people from other counties may come, not just other countries. And we have people get off the plane from Nepal who have leukemia, and someone in Nepal told them, you should go to Cook County. That happens a lot. But they're more resentful of people from Lake or McHenry or some of the surrounding counties coming. And that's because those other counties don't have a hospital, right? They don't have a place that will take care of poor people. And the docs have always been at odds. And at the end of the day, I'm a doc, so I say, we'll take care of the patient in front of us, and then we'll figure out the, finances for it later. So I probably am not someone they were always thrilled to have in charge, because I do try to stick to my values as opposed to what the CFO would want. But I do recognize that the better we are at collecting funds that we're due, that's more poor people who are unfunded who we can take care of. Before the Affordable Care Act, 56% of our inpatients were unfunded, people who had no coverage whatsoever, and 80% of our outpatients were unfunded. Since the Affordable Care Act passed, and Illinois is one of the states that expanded Medicaid, about between 62 and 65% of our patients are funded now. And that allows us to take care of the other, 38% who still are not funded because either they're in this country and they're undocumented, or what I'll remind people is that even when you immigrated to this country appropriately, with documentation, that you're not eligible for certain benefits until you've been here for 5 years. And I'm the daughter of 2 immigrants. Neither of my parents were born in this country. And I find our current attitude toward immigrants appalling and offensive. Yeah, Zach.
I just did a quick Google search. You can correct me if I'm wrong, but it seems like the attending physicians in Cook County are unionized.
They are.
Okay, I wanted to see what the motivation behind that was, or if you're aware of why
they've been unionized for a while.
Okay,
I can tell you about it.
Okay, sounds good.
They first unionized. My mentor, who talked me into going to medical school, they went on strike back in the late 70s, early 80s, because, and that's before there was really a house staff union in the country. But it's interesting what they were fighting for is they wanted to have an EKG machine on every unit. They wanted to be able to, in an emergency, have the equipment they needed on the floor. And what they did was they took patients who were ambulatory, and they put them in the old wooden wheelchairs, which we still had at that time. And they said, if you won't provide us the tools we need to take care of these patients, we're going to roll them across the street to Rush Presbyterian St. Luke's, or we're going to roll them over to the University of Illinois, because you won't provide us. They were on strike for some time. Now, some of them, they made an agreement, so some of them came in to make sure that patients weren't jeopardized. But the most recent iteration of the unionization occurred with SEIU Doctors Council, which came in here in 2007. The ambulatory physicians were already unionized, but in 2007, we had a really severe financial situation, and we were ordered to cut 17% of our budget. We never got to 17%, but it resulted in a reduction in services, and the physicians all signed union cards. I even signed one, though I wasn't eligible, but I thought it was right for them to be able to unionize because they were going to lay off physicians. And I just thought that that was a criminal thing to do. So they are unionized. I'm the one who's negotiated the last 3 contracts for the administration. But I do point out to some disappointment of some that the first union contract, we had pretty much reached agreement. And then at the last minute, when nobody was paying attention, I put on the table a raise for moonlighting rate, because our moonlighting rate was so low. And so whenever the union gets really huffy, I just said, ask your membership who arranged for their moonlighting rate to be raised. And it changes their tone. They recognize that I'm not hostile to the union. My father was a labor union organizer, so I come by it honestly. But the union helped protect the workers and protect their employment, and it allows them to have decisions made based on, in other words, so someone shouldn't be able to bump someone who in a different specialty because of seniority. It's just a rational approach. I mean, I don't agree with everything with the union. No one could, but I think it's the right thing to do, and it's fair for the physicians to be unionized. And 90% of the workforce at Cook County is unionized. I know I'm an unusual boss.
Yeah, you might be the only hospital administrator that had something positive to say about unions,
Yeah.
but I'm glad to hear.
We struggle with some of them, when they're arbitrary or capricious, but when they're really motivated to try to make sure that we do a better job in terms of taking care of patients, you can't fight that. Yeah, Kinsey.
I was wondering, I feel like you've mentioned physician burnout a couple times, and I was kind of wondering if you could talk about kind of what your experience with that has been, if you've experienced it at times and how you dealt with it, or why you felt like maybe you haven't experienced it.
I haven't experienced it, but I understand it very well. I mean, you feel like you're on a grind. You have a long day. Our primary care physicians, and I think it's in some fairly qualified health centers it's worse. But if you look at the work week and say, our outpatient operations are 6 days a week, right? And so we expect the physicians to work 8 sessions, 8 half days a week of direct patient care. So if you're working, a long day and you're seeing a volume of patients and you feel you don't have adequate support, right? One of my gripes is that it's easier to hire a doc or a nurse than it is to hire a medical assistant or a clerk. And so if you're a physician and you wind up doing clerk responsibility, when I'm seeing patients in the clinic, have to put my own patients in the room, if I have to go and get their medications, all these non-doctor things that you wind up having to do contribute to burnout. And so I think that, and I think that's the biggest challenge as a physician, and our docs, they take ownership of their patients. They want to provide their patients with the best care possible. But it's frustrating when you don't feel supported. So I think the most important thing as a leader is to be empathic, to be understanding. I think that comes from requiring all of our physicians in leadership roles to also see patients. So it provides them a little bit of humility. You know, when you have a nurse tell you do it yourself, or you can't find someone to help you assist you with a pap smear, um, you understand the things on the ground, and that's helpful. Um, but it can be um, a thing that if you're seeing patients and you're working, you know, 5 or 6 days a week, and you don't have all the tools you need, that causes burnout. And the way that we combat it is we try to find a little joy for patients, for providers. We um, have a lounge for them, or we have activities or things that remind you why you enjoy what you do, the camaraderie, or have activities where the docs get together and do something that's not patient related. So all those things help remind you and help you find the joy in the work that you do. And it's a challenge because the patients keep coming. We're never closed, and they're here every day, and their needs are tremendous. So, and in the current environment, it's gotten worse, but you just have to be there for them. Yeah.
What advice do you have for current and upcoming med students? Not just trying to, traverse med school and residency and trying to choose specialty, but to advocate for change. And also, like, what do you think? Actually, I'll ask that one later.
I think that it's important to study health policy as it is to study, the facts and data. Half of what you learn in medical school is going to be outdated by the time you hit the wards and start taking care of patients. We aren't going to be doing it this way anymore. We're going to be doing it that way. I remember hearing that when I was in medical school, and boy, was it true. Things change so quickly. It's exponential, but it's really understanding policy and being able to educate yourself and being able to have discussions. My son is a sports writer, but boy, does he have a command of the facts and the data. And it makes it difficult to try to squeeze out of a question he asks you, because he always has the answer. I think it makes a huge difference. When you're advocating for single payer, you need to know the facts about it. And we're publishing constantly. I think that you can't belittle or demean your opposition. People have their feelings about things, and it may be for totally valid reasons, but you can have discussions. First, you have to be able to listen. Being able to listen as a physician is important. And so being able to listen when you're having a debate or discussion is important. And hear what someone's telling you, and it's not just the facts that they're telling you. Sometimes they're misinformed, but they have these passions or these feelings because of there may be some real emotional tie to it, or connection, some experience they've had. But knowing the data, knowing that, how many economists have said that there is adequate funding in this country, 29 published studies about how much we spend on healthcare in this country, and yet we could fund care for everyone with the dollars that we're spending currently. So, when you want to challenge people, it's not to be confrontational, but to ask the question, why do you believe that? Or why do you think that? And then say, well, this is how I think about it. Or have you heard this study, or have you read this information? Just like I talk about prior authorizations, and how many of those, traditional Medicare in that time period, they had over 400,000 prior authorizations. They were much less likely to be overturned on appeal, because they used valid data in terms of making decisions about things that they would approve or not approve. So my advice for students, when I was a medical student, when I was an intern or a resident, and I had a disagreement with my attending, I would ask the question, is it why do you think that? And it wasn't a personal attack, or you didn't say that, well, that's stupid, or I disagree. It's like, but I don't understand because this is my understanding. So it's really your approach. I think diplomacy is what has allowed me, even though I'm fairly progressive in my politics, to ascend to a leadership role, because people don't feel immediately threatened by me, and they feel that I'm fair. And that's allowed me, um, the daughter of a labor union organizer and a social worker, to be the CMO of a huge system, is because I take that approach. I may vigorously or violently disagree, but I don't let you know that. And I remember people said that about my mom. There were people that she personally may not have respected, but she respected their position or their office. And so they never had an idea of how she felt about them personally. Um, and so I think that those are important things to remember as you're trying to navigate, because it's a complicated space. Medicine is very complicated. Other questions?
I did have another. And
ahead.
so throughout the internship, we've learned about all we've learned about single payer, and we've learned about more like steps towards it, like state-based single payer plans or the public option. In your
Mhm.
opinion, do you think for adequate change to happen, that it's better to take those incremental steps, the smaller steps, the state-based or the public option, or do you think it's better to gun for single payer?
I don't like incremental approach. The public option is Jacob Hacker's PhD thesis, and I sat on a panel and debated him about it. Um, and the reason I don't like them is because they don't provide the savings that a national plan would. And so the incremental steps will give them the opposition the opportunity to say, "See, we said it didn't work," because the numbers are too small to be beneficial. I think there are some states like Maryland that have um, done some things that are positive in terms of providing people with access. But I really believe that we have to do it on a national level. And I think that when we have, and it's the same problem with Medicaid, why do we have Medicare Part A, Medicare Part B, and and Medicaid? It's because there were three different proposals that what's his name? Was it Mills, Wilbur Mills, who tried to combine them, and it was because the Southerners did not want to have the hospitals were segregated. They didn't want to integrate the hospitals, um, and because we have a different Medicaid plan in all 50 states, Medicaid is federally mandated but state funded. Um, People can get access. You find patients who discover this, crossing from Wisconsin to Illinois to get services that they should be able to get in Wisconsin. We really need to have a standard, and I think that Canada demonstrates it well. They have these five basic principles of healthcare, that it is what they expect every province to meet that standard, and because the quality of care you receive shouldn't be based on where you live. It should be based on the fact that we as a country have finally accepted the notion that healthcare should be a human right. Um, and then if you take that, then the next caveat, single payer is just a financial conduit. It doesn't speak to the quality of care we provide. And I think that once we get to providing everyone with care, we can start talking about, how we make healthcare decisions. And, we have only so much funds, so what are the most important things to provide people with access to? So I'm very much opposed to incremental approaches, because I think that it's a divide and conquer sort of thing. You allow states to say, no, we're not going to provide this. And other states say, well, yes, we will provide it. And so then your healthcare is dependent on where you live. And that should not be the case. You should be able to get the care you need wherever you are. And as I said, we can afford to do it. We just choose not to. unfortunately. But that's my view. I've been, doing this for a really long time.
Dr. Fegan, we have you scheduled until noon today. Was that also your understanding?
Yeah, that's true.
Okay, perfect.
I'm going downtown to speak at a conference afterwards. So yeah. Other questions? You guys are too quiet. You have to have more.
I was kind of curious about the process of hiring ancillary staff, like you were talking about how difficult it is to get medical assistants and people who kind of just like make the whole system run more smoothly. So I was wondering what those challenges are, if you see a way to make that easier.
Well, part of it is because people, the majority of people who are in administration in hospitals are not trained as direct caregivers. And so oftentimes they don't understand the significance of those roles, and they think those are things or positions they can cut. And so when there's financial um, shortfalls or difficulties, well, how many pharmacists do we need, right? How many med techs do we need? Pharmacy tech. Those are the people who count the pills and put them in the bottle, right? How many of those folks do we need? Um, or how many clerks do we need? The people who are checking patients in when they come for an appointment. And so they are often the last hired and the first fired. I remember when Ruth Rothstein was alive, and she was the Iron Lady who ruled this health system for many years. She only believed in hiring doctors and nurses and trying to convince her or understand that doctors and nurses couldn't do it all. There were these other people that were so important, like the phlebotomist, like the otherwise the doctors were drawing blood, or like the clerk. So it's helping them understand the process. So it's incumbent on people like me and like our chief nursing officer to help them understand these roles and why they're so important in the bigger scheme of things. People who are outside of medicine really don't understand it's a team approach. A lot of docs don't understand it's a team approach. You learn it soon enough because in your internship you'll come to rely on those folks. But boy, you walk in and you think you're the doc, you're in charge, and everybody has to bow at your feet. But I learned very quickly that without the nurses, without the clerks, without even the housekeepers, you were nothing, right? Without the people who stock the floors for the equipment you need, so you could find the tube you needed in the middle of the night, or you could find the various things. So it's a problem helping people, helping the bean counters, the accountants understand the roles of these other positions that take, and that if you have one physician but you don't have all of those other supporting part, that physician becomes very inefficient. And then they're asking, why aren't the docs seeing more patients? Well, if they have to put each of their patients in the room themselves, if they have to weigh the patient themselves, then it takes them much longer to move through each patient that they see. So it's recognizing that medicine is a team sport and speaking up for it.
Great. Thank you so much for coming to talk to us. We really appreciate you taking the time out of your day and sharing your experiences with us. We want to be respectful of your time and make sure you can make it to your conference. So we will let you go, but thank you again.
Well, thank you, and I wish you all the best of luck. And look at Cook County when you're finishing medical school. It's a wonderful place to train. And like I said, I've traveled all over the world. I've been to Fiji and China and Africa, and there's never been a place I've been that I haven't encountered someone who hadn't passed through county at some point in their career. So look at us as a place where you might really want to provide care and have a good time taking care of people who need your care a lot.